All right. So hi, welcome to our hour-long roundtable discussion regarding the subject of creating seamless and integrative system between that of the community birthing and hospital-based professions. We have a panel of diverse providers here with us, where we'll be exploring not only the issues surrounding desired or necessary transfer of care between the community setting to the hospital setting. We'll be discussing the various research surrounding the best practices regarding this transfer while looking at how seamless integrative transfer improves birth outcomes individually as well as for the collective. Lastly, we will be detailing the steps you can take in improving these integrative relationships in your community and how we can create better collaborative systems overall here in the United States. My name is Jennifer Carvalho, and I'll be functioning as the facilitator for this roundtable. I'm a midwifery student at Thomas Jefferson University, and I'm honored to welcome all the participants of this roundtable, as well as all of you who are taking the time to listen and explore this topic. Before we introduce all the panel members, it is important to first highlight that birth takes place in many different settings, both here and worldwide. We'll be discussing what happens here in the United States with only some comparisons to other higher resource countries in this conversation. We'll only be staying with intent not to offer judgment on differing opinions of where individuals choose to have their birth, but instead the conversations will be in supporting the process of integrative care for all, including when the transfer of care is coming from the community birth setting to the hospital. We'll be specifically diving into best practice guidelines of transfer of care when the transfer is either desired or necessitated. Oftentimes using the traditional framework that already exists in our medical system, for instance, that of when what is an unforeseen adverse outcome occurs, for instance, when a newborn within an institution gets transferred from a labor unit to the neonatal intensive care, transfer of care in this spirit with community to hospital is no different. We'll be highlighting just some of the work of the following initiatives that have been created through research. The New York State Association of Licensed Midwives, abbreviated NYSALM guidelines, the Alaska Perinatal Quality Collaborative, abbreviated AKPQC Birth Transfer Initiative, the Washington State Smooth Transitions, the American Association of Birth Centers, abbreviated AABC, for their EMS toolkit, the best practice recommendations for handoff communication during transport from a home or freestanding birth center to a hospital setting, 2014 guideline developed by the Maine CDC, the Home Birth Summit and the Birthplace Lab, as well as lastly, the Utah Women's and Newborns Quality Collaborative, abbreviated UWNQC, Utah Best Practice Guidelines Transfer to Home from Planned Out-of-Hospital Birth. And that was made in 2020. With that, I would like to introduce the panel in no particular order. Dr. Susan Rachel B. Condon is a certified nurse midwife. She's a doctorate in midwifery, and she's in private practice in New York's Hudson Valley. She provides primary care across the lifespan and home-based perinatal services. She is on the board of her state affiliate and has served as regional representative and program committee chair. She was also a member of the Home Birth Integration Initiative of the New York Committee for the past 3 years, participating in the development of evidence-based practice guidelines. Currently, she serves on the National ACNM Home Birth and Birth Center Committee, where she's been a contributor to the 4th edition of the Home Birth and Birth Center Manual. Dr. Condon has been a preceptor for both midwifery and nursing programs. She was a member of the first cohort for the doctorate in midwifery from Jefferson University, researching obstetric violence, respectful care, and promoting midwives as role models for collaborative decision-making. She is presented on the topic of respectful care and New York City midwives. Go ahead and please mute yourself. Childbirth Education Association of Metropolitan New York, the Alden March Reproductive Bioethics Conference of the New York State Perinatal Association, and the ACNM annual meetings. Dr. Condon engages in innovative research and academia, has been published in the Journal of Midwifery and Women's Health, abbreviated JMWH. She is currently a peer reviewer for the JMWH in the Journal of Contemporary, Complementary and Alternative Medicine. Her scarce free time is spent knitting, weightlifting, and exploring the mountains near her home. So welcome. All right. We are expecting Dr. Stuart Fishman, but he has not made it yet. So we're going to skip him for now. Next, I would like to introduce Terry McCormick, a certified nurse midwife in the state of Pennsylvania, right? Terry obtained her Bachelor of Science in Nursing in 1985 and went on to obtain her Certificate of Midwifery Master's Program from Frontier University in 2003. Terry has worked as a CNM at the OBGYN of Lancaster Heart of Lancaster Hospital. She provides full scope midwifery care to women from various socioeconomic groups and ethnic backgrounds. She provides antepartum, interpartum, and postpartum care in collaboration with obstetricians and gynecologists within the practice. Terry has also been assistant professor of nursing at Alvernia University in Reading, Pennsylvania from 2012 to 2014. There she provided classroom and clinical instruction in the pre-licensure program. Some of those classes included curriculum development and teaching of maternity and advanced medical surgical content, including physiology, pathophysiology, and nursing care during the antenatal, interpartum and postpartum period and newborn periods. She's also taught advanced pathophysiology and nursing care to clients with gastrointestinal hepatic disorders as classroom and clinical instruction in the introductory medical surgical course. So welcome, Terry. Next, I'd like to introduce Kayleen Richard. She is the founder and owner of the Tree of Life Birthing and Gynecology. She's a certified nurse midwife and an ARNP in the state of Florida. As a nurse midwife, Kayleen has worked hard to be able to offer families all birth options, that of home birth, birth center, and hospital birth. She has started out as a doula and a childbirth educator before getting her RN degree. She believes all women benefit from receiving prenatal care with a midwife that provides the hallmarks of midwifery care, including emphasis on education, partnership, and supporting natural physiologic childbirth. Kayleen has 3 amazing sons, 2 of which were born at home with a midwife. As a healthcare provider, she encourages natural remedies for healing and continues to increase her knowledge in this area. Kayleen takes pride in providing full scope of care, including having prescriptive authority. Kayleen believes all women deserve to make choices during their birth process and feels it's an honor to help offer natural childbirth options to families in her community. Kayleen founded Tree of Life Birth and Gynecology in 2011 and has owned and operated 3 birth centers in that time. Tree of Life is nationally accredited and has serviced over 1,000 families and averages 25 births in each month. Kayleen is also actively involved in state legislature, recently getting the CNMs in the state of Florida and nurse practitioners greater autonomy in practice, and in order to be able to serve full scope of practice to service their community needs. So welcome, Kayleen. And next is Liz Whitaker. So thank you for coming, Liz. Liz is a certified nurse midwife that was involved in Smooth Transition Initiative of Washington State. Liz has lived, worked, and raised a family in Kittitas County in Central Washington for 40 years. And it's about 100 miles east of Seattle. It's a very rural agricultural community, population about 45,000. Liz decided to pursue nursing as a career after a devastating event disrupted her life in 1991. Liz wanted to become an OB nurse, but due to life-work balance, work in the public health arena has always drawn her back. She's worked as a public health nurse. She feels very fortunate to have worked in a multitude of public health programs and initiatives, especially areas where the focus was on healthy children and families. In 2011, Liz returned to study nurse midwifery because she recognized that her community needed local midwives and more support for birthing mothers. Once again, public health called her back upon a graduation, and she got even more experience in new areas of public health, including communicable disease, harm reduction, and the federal Vaccines for Children's program. Liz recently retired from public health in 2019. Liz's other interests include growing raspberries, singing in a women's chorus, and volunteering locally, as well as being an involved grandma. And last but not least, Kate T. Finn is a bunch of different things. She's MS, LM, CM, CPM, FACNM. Liz is recently retired as a private practice licensed midwife in Ithaca, New York. For 30 years, Kate's full scope of practice provided well women, maternity, and newborn care with a focus on planned childbirth in the home. From 2000 to 2005, Kate offered clients choice of birth settings of home, birth center, or hospital. Kate was able to transfer clients to a hospital and continue as the primary provider within collaborative, team-based model practice. As an activist midwife, Kate has spearheaded local, state, and national efforts to engender a safety agenda for maternity care in the community setting through quality assurance activities. She led a 10-year process of consensus building in New York, resulting in development of a safety bundle for community birth. The bundle includes professional organizational guidelines for collaborative care between community midwives and hospital-based providers that places clients at the center of their care planning when higher level care is indicated. The name of the birth in the community setting in New York, new NYSALM Best Practice Guidelines of 2020. Additionally, key maternity system planners as select regional perinatal centers were engaged and equipped to develop internal hospital guidelines for receiving transfers from community midwives. Kate serves as the chair of the quality committee for the New York State Association for Licensed Midwives. So welcome, Kate. So welcome to you all, and thank you all once again for participating. This is a roundtable and conversation is encouraged. Professional decorum will be followed by allowing each person to finish their thoughts in a timely manner. And let's dive into the first question. Once again, as long as there is no background noise, feel free to leave yourselves non-muted. And basically the first question for anyone is if someone would be able to highlight the birthing landscape in your particular state, what you've been exposed to, or nationwide. For instance, percentage of individuals birthing in the community setting as opposed to the hospital setting.
I'm Kayleen Richards, and I own the birth center, like she said. So at one point, I had hospital privileges. I am autonomous. We just got that last year in the state of Florida for nurse midwives to be autonomous. However, there is a little glitch in it where we do still have to have a written referral paper that says I have a doctor that I refer to and a hospital that I refer to. So I am currently trying to get privileges again as an autonomous nurse practitioner and not be sponsored. So that's currently where I'm at. But we do home birth, birth center birth. Like I said, I did do hospital and just stopped about 2 years ago. In Florida, only about 5% of births are occurring outside of the hospital. We do have a strong licensed midwife association as well as licensure in the state of Florida. Florida School of Traditional Midwifery has been around since the 80s and produces about 10 to 15 midwives a year. we generally have a student, 1 or 3 students at the birth center majority of the time. So there is a strong presence of licensed midwives, home birth midwives. Currently in the state of Florida, I am one of 4 nurse midwives doing home birth. So we do not see as many home birth nurse midwives due to the strong presence of licensed midwives providing those services. So most nurse midwives are practicing under a supervising physician in a hospital setting. We have in the last 3 years seen a strong presence of nurse midwives fulfilling like a hospitalist role where they're employed by the hospital and doing like 12-hour shifts. I hope that answered the question.
I can talk about my experiences in Lancaster County, Pennsylvania. We do have a fairly large percentage of women. I don't have the numbers at my fingertips, but it's usually around 10% of the births in our county occur outside of the hospital. We do have licensed midwives practicing in solo or dual home practices. And we do have a large majority of unlicensed midwives also doing home birth. Our practice in particular has worked very hard over the last 10 and 12 years to establish an open line of communication and respect. We have a system in our practice where the midwives have a point person in our office that they can call if they need to consult with us at any time during pregnancy. We have all the home birth midwives have a direct phone number to the midwife and the physicians that are in the hospital for their 24-hour shift so that we can have smooth transfer of care at any time. We openly encourage sharing of medical records between the midwives and ourselves. And we're pretty proud that most of our midwives in the area are very comfortable having one visit in our office and then maybe going back and having a home birth or having a consultation visit in our office, then continuing with prenatal care with their home birth midwife, and then just coming to us for delivery. Our hospital system offers a self-pay plan, which is very competitive to draw in those the Amish and Mennonite women who are self-pay. They get deep discounts. And so it works very well where we are. I can't speak for the rest of Pennsylvania. I can only speak for where I am.
I can speak a little bit about New York. New York is enormous. And it's really, really different when you're in the tri-state area versus out in more far-reaching rural areas or other small cities. I have practiced in New York City, it was many years ago. When I first had a home birth in New York City, there were only 2, maybe 3 midwives covering all of New York City. And now there are dozens. So I'm not sure about the actual figure of how many people plan home births, but it's quite a few. And unfortunately in New York, there are very few birth centers. We have recently, now it's several years ago, we passed a law that said that midwives can open midwifery-led birth centers, but the regulations are still not settled. So we have very few birth centers. I live about 100 miles north of New York City now in a pretty rural area. Liz, do you want to mute yourself? I think that's noise in your background. So I serve 4 counties in my practice with one partner, and there's in each one of those counties, there's a small city and a lot of rural. So it really varies depending on where we are. Our collaborative relationships have been very, very good. And we had hospital privileges for 3 years. And we initially got the hospital privileges so that we could transfer people and have a more seamless transfer. And also, you know, one of the approaches that we had to the hospital that we went to was a small inner city hospital, very low census. And we basically said to them, you know, midwives have sizzle. So if you have midwives in your hospital, people are going to be more inclined to go there because of the kind of, you know, trust that happens in the community. And after obtaining privileges and working there for several months, we actually said to them, how would it be if we also offered planned hospital births for people who either shouldn't have home births or don't want to, but still want this kind of care? And so we had a pretty successful practice going for a couple of years. And then the hospital was eaten up by a larger hospital entity, which had no interest in supporting independent midwifery. So we all went our separate ways. But we still have good collaborative relationships in a number of settings. Sometimes we transfer midwife to midwife. Sometimes it's to a physician, but for the most part, everyone kind of knows of us. And so we feel like we have the credibility where we can call and we can say, this is what's happening. This is what we need. Can you have that ready for us? And they're pretty respectful about it. The one issue that I have had that I would really like to have a better system for in our area is if we do have a problematic transfer and then we request a meeting to review the case afterward, there's a lot of yesing and then it doesn't actually happen. Or it happens on their terms and it doesn't really feel like the kind of case review that we need. So when I approach the hospital, I'll say, we had this case, you had this case, and why don't we think about how we all could have done better so that in the future things go more smoothly, and knowing how risk averse they are in terms of liability, kind of bringing that to the table and saying, I think we both could have done better and it'd be great to talk through it so that perhaps in the future it reduces liability for both of us. So that's just another little piece of it in our area that I'd like to see improved.
We work on that continuously in our practice. We're really lucky that we have one physician who is very dedicated to working with the home birth clientele. And so she and I have a monthly dinner with the home birth midwives. It's real informal. Where do you guys want to meet? Obviously it was Zoom during COVID, but we just had our first in-person one outside again. And so once a month we meet, it's over dinner. They bring charts. We talk about how things are going, any of those cases in the last month that didn't go well. And that informal setting really helps, I think, everyone understand each other. Even though there is mutual respect, the practices are different. And so just having that constant dialogue, I think, really helps. And the other thing we do is once a year, we have a luncheon. And we invite all the home birth midwives, whether they're licensed or not, and we offer really inexpensive CEUs. And oftentimes we'll pick a topic. Like 10 years ago, we did groupie strep because the unlicensed midwives weren't getting groupie streps done. And it was costing their clients money when they came into the hospital and unnecessary antibiotics. And so we just talked about groupie strep and we offered it for $14 and boom, everybody was doing groupie streps at home. So that has helped the situation that you talked about a lot.
Terry, is that a that's initiated by the actual medical practices though, and the hospital has no voice in that, or
which part?
Just having the meetings.
Yeah, I mean, Dr. Livingston and I have been doing them for years. Our hospital is small. We are the only OB practice at that hospital. We have 7 midwives, 7 obstetricians, and we've been owned by, this is the 3rd takeover we've had. So I can't say that we've ever asked for approval from the healthcare system, but even when COVID hit and our home birth midwives were having 100% positivity rates in July of 2020 with COVID. And we went to them and we said, listen, horse and buggies can only go 14 miles in one direction. Unless they're hiring a driver, they're not going to get a COVID test. And the healthcare system came and we got COVID tests for those home birth midwives so that they could get that testing done. And then we brought them back. So I think the key to the success is having a physician that's very vested in that community. And I really help as a liaison as the midwife. And so, and that brings the healthcare system in with what we're already doing.
So I think I'll piggyback on that because both Terry and Susan Rachel were very good in talking about some very specific things on a local level. And I just wanted to talk more about the systems wide work that's also happening in New York.
Kate, can you also, because you're obviously all very familiar with this subject. Can you also include just some of those little details for those that might not be as familiar with, like, what's the problem? You know, is there a problem? Maybe those hospital-based providers that really don't see a lot of transfer and don't see the problem. So maybe talking a little bit about like transfer percentages and still going a little bit more into the problems, but please continue.
Okay, yeah, and I think that Liz will also have a lot to say from the smooth transitions perspective, because these two were somewhat parallel projects that were happening on different sides of the country, but trying to address the system approach to the problem. And what the problem is, has been and is evolving and growing, is an awareness that the choice for having birth in a setting outside of the hospital is in fact a reasonable choice for women to make based on an increasing body of literature and based on personal preferences and sensitivities that pregnant person, that family has. And if they're making this choice, whether it's for the religious purposes of what we're talking about, maybe in Lancaster County, Pennsylvania, Amish and Mennonite, or if it's an educated choice, like in Ithaca, New York, and their Cornell professors of finance and restaurant management, whether that whole entire spectrum has the right to make these choices and has the right to receive standard high quality care, both through the maternity care cycle from the midwife, whether they're licensed or not licensed, and also then when those transfers need to happen because there is an indication that a hospital bed is a more preferred place, probably a better outcomes, higher level interventions that are available in those settings, that those transitions between care settings, between care providers happen in accord with how transfers happen throughout the healthcare system. And because we know that those transfers, when they're coordinated well, will go better and have better outcomes, lower chances of adverse outcomes when there's good communications and a seamless transfer. We know that from every other healthcare modality. If it's a family practice doctor transferring a case to a cardiologist, we know how those transfers work the best. So it's a patient safety and quality priority. And what's happened is we have to sort of come forward with that perspective so that people who are on the receiving side of these transfers don't feel put out, don't feel like somebody's imposing upon them some other case that they didn't expect to have, because these people are specialists. Or in the case of Terry, they're open-minded generalists who can be helpful. So it's not just that we need to have OBs who are able to do surgery like the cesarean sections. We need midwives in those hospitals to be able to take over for the tired mama, the one who needs the epidural or the Pitocin, which doesn't need to have a physician involved, except in the collaborative care model. So that's kind of the statement of the problem. I don't know if anybody wants to add to that. I'll just go on then and talk a little bit about the system of New York, which was 10 years ago, there wasn't a lot of collaborative dialogue back and forth. And that was a patient safety problem. We don't want to have people coming into the hospital and being yelled at, or people be coming into the hospital too late because the midwife is afraid of what's going to happen when they take the patient in. So we looked at the system and we said, well, the best way we can do this is to create a maternity care safety bundle around community birth in New York. And this was a philosophical, theoretical basis that we started from. And that safety bundle was already a language that was being used and adopted in other areas of maternity care. And the 4 elements of the safety bundle are is that we have a well-educated group of midwives to provide the care, and that we have a regulatory structure that allows midwives to practice at the top of their scope with the safety equipment that they need. And New York had those two already in place. And what we didn't have in place was this articulation of what quality midwifery care looks like. What do the safety studies show? and what is the best practices, and how can we find out about the best practices by looking at areas of the world where best practices are occurring, and there's studies to show that. So we did a survey of all the world best practices and bundled that into the documents that we're going to talk about tonight, which include a guidelines for what we call collaborative care, not site-specific parameters, but collaborative care parameters. And then the third thing that we need is that we need hospitals to be able to step up to their role and create policies for receiving these transfers, because for example, regional perinatal centers receive transfers from other hospitals when there are higher level care needed as you go up the tiers of the maternity care cycle. And so we can slot home birth and community birth centers into that transfer protocols, and that's what we've done in New York. Liz, do you want to add on from your?
I'm sorry, I'm afraid I'm in a noisy environment because I'm not at home right now. I'm in a Starbucks.
You're fine, Liz.
But yeah, I mean, my experience compared to the rest of you midwives is rather peripheral. First as an OB nurse, when we had only a lay midwife in the community and when the transfers were always problematic. There weren't very many of them, but it was always very apparent that there was friction between the lay midwife who was, who would be there but wasn't allowed to do anything in the hospital, and the providers who ended up having to, and the nurses. I mean, I was pretty horrified as one of the nurses, seeing how some of the other nurses were so negative about both the lay midwife, who was not unskilled, she just wasn't licensed, and her people, who were almost all at that time, that was like 20 years ago, they were all choosing home birth because they were terrified of being in the hospital, and then they ended up there, and it was horrible. And now my experience is that lay midwife quit quite a while ago. We had a certified nurse midwife who worked for an obstetrician at the time. Our little hospital sounds like it's much smaller than most of, even though some of you are in rural areas. I mean, our little hospital here does about one birth a day, average. So there's about 350 births a year. And I'm even not, and I've assisted our license, now we have a licensed midwife in town. It's the only, and she's recently hired a certified nurse midwife, and there's also a family practice and a women's health organization practice that are owned by our little hospital. Our hospital is a public hospital, it hasn't been taken over by some conglomerate private healthcare. So I think we're fortunate on that level too. But so the women's health practice has a certified nurse midwife working for them now too, but we don't have a whole team of midwives or obstetricians. In fact, we don't have a single obstetrician in our community anymore. We have, I think, a couple of family practice docs now who sort of specialize in OB, but so our folks who need a really higher level of care might have to leave our community to get care in a different hospital entirely. So, but when this new licensed midwife came to town almost 10 years ago, she just made it a real priority to meet the nurses at the local hospital and to meet the local providers and to talk to people and she got involved in the perinatal collaborative, the local perinatal collaborative, and she asked me to go to some births with her, and I still knew a bunch, because I've lived in the community for so long, I still knew a bunch of people who are involved in healthcare. So, and I don't know, I probably only assisted her at maybe 8 or 10 births total, and those 3 of them ended up transferring to the hospital for one reason or another, and all went pretty smoothly because she works, I think, in our community, the personal relationships are just so important. And it sounds like other people have done that too. But then we also, because we are such a small hospital and have only such a certain level of care available, it was really important to collaborate with the whole region. And the next largest hospital that has a higher level of care is about a 45-minute drive away for us. And they also have a NICU, so sometimes our babies get transferred to their NICU, and sometimes moms get transferred there too. So, or sometimes they get transferred to Seattle, 100 miles away. It's a couple of hour drive if road conditions are good, because it's over in a mountain pass. Actually, there's mountain passes almost every direction from our community, so in the wintertime, sometimes things are bad. Anyway, but the smooth transitions process, I mean, we figured out, who's the person, what are the phone numbers to call, who do you talk to, how do you get your patient transferred directly to the obstetrical unit instead of through the emergency room, things like that. And I'm a little bit out of the loop now. I've retired and I haven't done it lately, but I think it's working pretty well right now. But it's very dependent. Like if this licensed midwife were to leave our community, we'd probably have to start all over again. It's very personality dependent. And she also has she's young and she uses electronic medical records. So when she does the transfer, she can easily print out whatever she needs or I don't know, send a secure email to the hospital setting, that kind of thing. And she does all and she's keeping up with recommendations, and she does all the usual testing and things that are expected of women who are birthing in hospital too. And she talks to her patients before she even accepts them as patients about her plan for transfer, in case, so that they know that if they risk out of her practice, they know that she will not take care of them anymore, or she might have to collaborate in order to continue to care for them.
I think Liz is actually bringing up a really, really important thing that's true across the country. And you saw this in, if you saw ACNM when they talked about in one of the inaugural presentations about the workforce. And we're talking about the workforce in any setting, that there are just so many parts of the country that have no maternity care perinatal providers at all. And, it's a really, really serious problem. And you start to hear people talking about midwives as being part of the solution for that. But you also hear a lot of people sort of pulling back away from the hospital and being more interested in being in a community setting. So I think that we're on the threshold of seeing perhaps an expansion of the number of birth centers. And certainly when I go to speak at schools or when I get students coming to me for precepting, they're just younger and younger. It seems like, there's definitely a strong interest in entry into this profession. So I'm trying to be optimistic about it, but it's very frightening to look at the map and see all those areas that really have no perinatal care, where somebody, even in New York, where somebody would have to leave their county to go to another county to have a baby or to get a prenatal checkup. I think we're the solution for that.
And it's worrisome, isn't it? And all the small community hospitals that have closed too. So that's part of the reason people are having to leave their counties to deliver their babies.
This is Kayleen again. I just wanted to mention my biggest challenge is EMS. So I have great hospitalists and CNMs that I can transfer to. I have about a 9-minute ambulance ride, and I have these 5 big men that come in and have literally said that they're more trained to deliver a baby than me. And so I have been working with the director of EMS, the medical director. I had a sit down, 8 of them came in and sat looking at me, and trying to educate them on what we do. And the fact that it's, they said, once we call, then, and they come in, that patient is their patient. And so there's this attitude of just basic education. And I've tried to say, look, like put an IV in, do these things, but we need to have an SBAR tool. We need to be able to give report and get the patient. I don't need you to do anything. I need to get to the hospital. We had an excellent situation where I had having a 4, pair of 3, came in hot and heavy. We're setting things up, checker, 8 centimeters, foot in the vagina. From the moment I called, baby was out 22 minutes. So we went right to the OR. The team had the OR ready. And so we, when I call my hospital and I say, hey, this is what I have, I can get direct admits, even without having hospital privileges. Being a home birth midwife, this is, doing home birth, this is specific to Orange County. When I go to Volusia County, Lake County, the EMS is like, let's go. What do you want us to do? Get on board. So there is still a little bit of a good boy club is what I feel like we're coming up against, as well as a lack of education. When I talk to the medical directors of the EMS, there's too many. I'm like, too many EMS. I'm like, I just want to deal with station 41 that comes 90% of the time, and even if I educate 2 of those people, so it has been kind of gotten back to like bringing donuts and saying hi and handing out some basic handouts saying, this is who we are, this is how we're educated. When you come, this is how we can transfer. And then, and I've asked them, and with my other birth centers in other counties, I was able to do EMS drills. They would come, not 911, and just practice. I would say this is just as much as for my midwives and my employees who don't do it as well. Yes, I'm a nurse midwife. I worked in hospitals, but for some of the licensed midwives, because we have nurse midwives and licensed midwives working at the birth center, they've never been in a hospital and they are intimidated. And so we need it just as much as you. So there is still just this lack of education, even though licensed midwifery has been legal in the state of Florida since '78. There's still a lack of, I think, education and misunderstanding. And I too believe, we're seeing our smaller OB units closing. We have these really only level 3 tertiary cares. Birth centers and midwives are going to be the option for this interim, right? For these low risks, because it's going to be impossible any other way. So we have tried to adopt the Washington Smooth Transitions. The licensed midwives have gotten a committee together. Right before COVID, we were April 14th of 2020, we were doing the evidence-based birth. Actually has like a CEU 3-hour presentation that we were going to do at the hospital, inviting EMS. And of course, that all fell through. And so now I'm still just not even getting people answering my emails for directors of the units and things like that. So sometimes it does feel like, we take 2 steps forward and then 3 steps backward.
We have.
I wanted to just piggyback on what Kayleen said, and then Terry. It's really important to know that when midwives are making the decision to transfer, there are several options on how they transfer into the hospital. One option is to call EMS if there's an urgent need, or you think that the person might have the potential of delivering en route. That way you're in that kind of facility. The other is for a routine standard transfer. Midwives do take people in, they go in their private cars. Mm-hmm. So that's something that might be information that a hospital needs to know, is that coming in a private car is actually a standard of care, because we avoid then some of the delays that can happen with EMS. And the second thing I wanted to just highlight that was said earlier is that we do think that coming in, and this is national standards, and every hospital should adopt these standards because they are national standards, and one would have liability if you didn't adopt this, is direct admit to the L&D unit. If you're going in through the ER, that's going to be delays again. And anytime we have delays, whether it's EMS, ED, or a physician not available to take oral report, those areas are the transition twiddles that cause the adverse outcomes and delay or create less than smooth transfers and increased liability. So I just want to put that out there so that everybody who's listening to this understands that the standard of care is the midwife makes the call to transfer, makes the decision to transfer either by EMS if it's urgent or birth likely, maybe possible in a winter storm or something, or the most common probably 80% or more than 80% would be by car, and that the ideal is to come in directly with a phone call to the labor and delivery, a report to the receiving provider, and then directly walk through the door to the labor and delivery without any other delays. Thank you.
Yeah, I agree with Kate. I was going to say most of our ladies, our childbearing ladies, come in the midwife car. And of course, we had a birth in a car last week. So she almost made it. She made it to the door and she had the baby in the car. But, you know, the one thing I've heard a few people touch on is how psychologically scary and damaging it is for women who transfer from home to the hospital. And for many of these women, they've never been in a hospital. And so we encourage their midwife to stay with them the entire time. And if they have someone else birthing or it's in the middle of the night, they'll go home and we'll make a call and say, hey, she's going to deliver in an hour or so. And they'll come in and be with them for that birth, especially if you have an intrauterine fetal demise or any difficult situation. They don't feel abandoned by their midwife. And sometimes their nurse will come instead. If they're at another birth, their nurse will come and stay with them. And even in the office, when we're consulting in the office, the midwife is encouraged to stay with them and develop the plan of care with them. And so, you know, you have to recognize that that can make all the difference for these families.
So I want to interrupt for a second and just get a quick introduction. Dr. Stuart James Fishburne just joined us. And I just want to introduce who he is to everyone in case no one knows who he is. He is a board certified OBGYN, American College of Obstetrics and Gynecology ever since 1990. And he's been practicing in Southern California since 1986. He is well trained at Cedars-Sinai Medical Center and Standard Medical Model of Obstetrics, but saw very early on the vision to support the midwifery model of care and has served as a backup consultant to many home and birthing center midwives for 25 years. In 1996, he founded the Woman's Place for Health, Inc., which is a collaborative hospital-based practice of certified nurse midwives and obstetricians in Ventura County, California. He has written many books. He has a podcast and written many different articles, as well as kind of just kind of condensing your thing, Dr. Fishman. But his podcast is called Birthing Instincts Podcast with the midwife Colleen Bliss Young, who's a licensed midwife. He's a preceptor for midwifery students from several different universities. And still actively cares for pregnant women while teaching hands-on seminars on breech birth. And I believe you also do twin vaginal births, I believe home, is that correct? And so just to catch you up a little bit, Dr. Fishman, as we were talking about the issues that we see in our state and nationwide regarding community birth to hospital transfer, as well as we've already started diving into some of the solutions. So welcome, and we can continue with the conversation.
Just a couple things. I'm sorry about being late. I thought it was 7:30 my time.
Oh.
And I just got your email because I just happened to check your email. I was just watching a documentary on television, so it's my fault. You know, I don't know why I put it down at 7:30. Two things. First of all, I'm no longer board certified. I've chosen not to do maintenance of certification. I think it doesn't represent my needs to do annual recertification, which used to be you were certified for life, and then they changed it to every 10 years, and then it was every 6 years, and then it was every year without any evidence to show that there's any benefit to that other than somebody making financial gains on. So I've decided to, just like a lot of things that I do, to do what's good for my practice, good for my clients, but I'm not. So when you said I'm board certified, I was board certified in 1989, and I was board certified for 20 years and then chose not to continue. I've only written, you said I wrote books. I've only written one book, lots of papers and stuff like that. So just want to be correct.
Mm-hmm.
when you say that, those sort of things. People can find out more at me at Birthing Instincts. The only thing I heard was Kate's initial comments when I just tuned in. I couldn't agree more with 100% of everything that she said. So I have nothing to add. Other than coronavirus has made it a little difficult. I don't, maybe I've missed some of this already, and it's really hard to come into a conversation like this in the middle. So again, I apologize. But coronavirus, we used to always go with our clients to the hospital, go up to labor and delivery, give verbal report, hand over, records and stuff. And for the last year and a half, that really hasn't been possible. So we do what Kate said, where we call ahead, we talk to the people, and we would like them to be directly admitted, not get tied up, because they're all coming in by car, but they've had it. They're coming in usually for a reason that's not emergent, but they don't need to spend another hour answering silly questions and filling out forms, that sort of thing. So I'll leave it at that, and I'll chime in as things go along.
Mhm. So I know that we planned on doing this within the hour and finishing in 5 minutes. If anyone does need to leave early, please, thank you so much for, but we really just want to finish up here by talking about some of those tangible solutions, just really highlighting what other people can do that you guys are already doing, that you have, the Birthplace Lab and a lot of the research that's supporting it. So if we can just finish off with that, that'd be good.
We have a document with business cards in an envelope, stacks of them in our call room. And every time we have a woman come in from a midwife in the community that we're not familiar with, we make sure that we give that to her and she gives it to that midwife. We keep an updated list of the community midwives so that we can be sure to invite them annually to that luncheon. And we invite them to that monthly dinner meeting, because the more face-to-face you have with people, the harder it is to be judgmental about them. And that's another reason we bring them into the hospital with their clients. And I think that attitude comes from the top. And when the physicians and the midwives are respectful of the home birth providers, then the rest of that staff takes that lead from you.
I guess I'll just say from, again, the systems-wide perspective, the organizational perspective, if the organization, the midwifery organizations of the state can look at some of these documents for standards of practice, indications for collaborative care, those kinds of statements like what you see at the NISALM guidelines for community birth. This Smooth Transitions also has a similar document. I'm not as familiar with the recent documents from Alaska and Maine, but I'm probably pretty sure that they do too. When you have these kind of articulations, it's a trust building tool. And it says, these are the situations where we know it's good to have our clients have a conversation, have a review, have an assessment by a collaborator, whether it means that the person comes back to the midwifery care with new information from the collaborative side, or if they then plan to make the transition to the hospital based provider. I think somebody mentioned, Terry, that prenatal care evaluation, and then go back and have prenatal care with your community midwife, and then go back to the hospital if you have a risk condition. All of those kinds of things, if they're outlined in a standardized document saying this is our view of what's best evidence, that really helps build a sense of trust for that relationship to get off the ground. That's a foundational piece. I've literally had physicians that I've approached in the hospital look at that document for 15 seconds and say, yeah, we can work together. This sounds good.
I was going to kind of piggyback on that. I think transparency is really important as well. And so for anyone listening, trying to get into the local hospitals, being able to present at an OB meeting, part of that is, providing your statistics. I think once they see statistics, we try and review our transfers. At one point, pre-COVID, we were sitting down quarterly, kind of same thing, like what can we do better? What's the feedback of the client? I mean, ultimately it is going in with respect and with the assumption that everyone's doing their best and we all really want the best for the community. And usually there's just a few outliers when it does happen. I think I love the idea of being able to provide cards, so I try and be very transparent as well as reachable for hospital staff as well as for EMS staff. I love the smooth transition where they have the online survey. So anyone who participated, whether it's the EMS, the client, the family member, the nurse, the doctor, has an opportunity to be able to fill out that form and not even put their information, right? So that makes, I think people want a voice. And so when people have a thank you. When people have a voice that, I think the next step though is to be able to have a committee. And so in Florida, again, we're trying to get a smooth transitions committee that then looks at the documentations, whether it's a complaint or whether something is good, to be able then to address state policy and procedure with that. I have taken my big old thick birth center policy and procedures up to our transferring hospitals. We have two level 3 tertiary care centers. So that way it's sitting there, and I've gone in during transfers and seen it like tucked away, but at least it's there and no one can say I'm not trying. I always try to have the attitude that, we're all on the same team. And I think especially as leaders, we need to have that intention that we're all on the same team. And when people act out, it's generally for fear. And I've come to see that it's really a common fear, which is the fear that we're doing no harm and the best thing is happening to the client. So that being said, it's important for us to also educate our clients. So we do a risk assessment at 36 weeks, and we do an emergency plan of care, whether it's from the birth center or from the hospital, that kind of outlines how we go, when we go, where we go, so that we, as it's happening. For home births, we always print out the documents so that way it's sitting there if we do need to transfer. And then at the birth center, it's fairly easy. We have an electronic health record system, so we can fax it, we can give it in hand. So I think, as members of the community birth its team, it is important that we also ask, what do they need from us? And one of the biggest things was records. Again, my EMS in Orange County, where my one birth center is now, will not let me ride in or on the bus, which is very frustrating. So I'm following, behind my car, in my car behind them. With COVID, of course we weren't let in. We are being allowed in as providers, not just as family members again. So that's exciting. But to give that face-to-face verbal report, to me, is transparency. It's feeling confident in the care that you've given, but it's also then allowing the best continuity of care. So, when it is a large hospital, we give report downstairs to triage, but what gets reported to the actual hospitalist on the 5th floor in labor and delivery sometimes can be different. So COVID taught a lot of patience, because I would tell the patient, just put me on speakerphone. So they would be in and I would be on speaker in the background, just being able to clarify, no, she had 3 doses of antibiotics, not just 1, or different scenarios like that. And for the patient, for the client, I often say we're the lifeguard, right? You're out too far, there's a rip current over here, otherwise swim away. To be able to continue to kind of protect them and stand by their side, I think is a benefit to the hospital as well as to the patient, as well as to ourselves. It's what decreases lawsuits, and overall helps the client then process the birth and go on to feel empowered instead of traumatized.
Mhm.
I agree pretty much with what everybody has said. The only thing that I would add is that one thing that's been very helpful for those of us who work in my area is regular peer review. And we take it really seriously. And not only is it an opportunity for us to review the cases when we transfer and to learn from each other, but it also, I think, really provides an opportunity for resilience, because it can be very stressful to be a midwife who is transferring from the community setting when things are not just, oh, somebody needs a little therapeutic rest and some Pitocin. If it's a really, really hard transfer, we need support. And, I've been listening a lot in the last few months, especially with the Home Birth and Birth Center Committee. We've been talking about the second victim phenomenon, and to have it really be acknowledged and to be there to support each other in a real empathic way, I think is another important piece of the puzzle.
I would just add that in California, at least in my area here, it's very haphazard, that sort of transport support that we have. We have some physicians in certain hospitals who, if they're available or on call, it's really always very smooth, and the respect for the client's wishes are great. And then of course we have some hospitals where everyone knows we don't want to go there. And so a lot of times our transport decisions are made, interestingly enough, sometimes based on traffic, because we know that instead of driving to the hospital that's 12 minutes away, we're going to drive to the one that's 47 minutes away, because they're going to get a better reception there. So, you know, it's really nice when we have those sorts of relationships with people. There just aren't enough of them out here. And there still are a lot of, as somebody said, fear. I think Kayleen said that there's a fear-based thing. Whenever somebody comes from home, they think it's going to be this disaster problem. I still remember just an anecdote. A woman that I had, it was her first baby. She was like 36 years old. She'd been in labor for about 20 hours. She'd been complete for maybe 4 hours. The baby had not descended. Her vital signs were fine. Her GBS was negative. Everything was absolutely fine about her, but she was breech. So, you know, I'm giving this report and I'm speaking to the head doctor at this facility, and she's taking everything in. And the minute I said the word breech, is like everything else I said didn't matter. It was just, they heard the word breech, and it's like panic. And it's like, well, the baby's not going to fall out. She's got plenty of time. She's going to come in. She knows she's coming for a C-section, but they were still, I didn't have somebody with, because of her system and the insurance she had this big HMO here in Southern California, that she couldn't go to anybody that we knew. She had to go to the place where she gets what we lovingly call doc in the box, whoever's on call. And that's a crapshoot. And it'd be really nice if we could go into these facilities and have, like somebody said, have a lunchtime seminar. One of the midwives did do that here locally at one of the Kaiser facilities here. And she was very well received, and they had no idea that we had IV stuff. They had no idea that we had Pitocin. They had no idea that we knew how to do CPR or any of that stuff. They just assumed, I think we went with boiling water and a shoelace, and that's what they think. And so I think that doing things like this is great. Some of you obviously work in hospitals, and you're trying to get these programs started. It'd be really nice if we had some sort of, in the training period, where midwife students are still students and residents are still residents and nurses are still nursing students, and they all did cross training together, where the home birth midwife got to spend a month in labor and delivery, and the labor and delivery resident got to spend a month with a home birth midwife, or just even had to sit in labor and delivery working as a labor nurse. So they actually saw what labor is like, because most people who go through residency never watch a woman labor. They don't know about the sounds they make and all those sorts of things. So, anyway, I just think that in California, it's really still very peaceful.
In some ways, I think I live in this really small rural community. And because it's such a small community, we know each other, and it's easier, even though you're not necessarily sure who's going to be on call that night, because the people you want can't always be there, because there just aren't that many of them. But it's still it's easier just to know who's there, because there aren't so many people that you can't keep track of them.
I guess I just want to emphasize my last statement. We emphasizing that hospitals themselves need to take responsibility for the safety of the people coming in their communities. Community-based care is a reality, and so I would really encourage anybody listening to this from the hospital perspective, from the hospital side, to engage your safety officers in your hospital, your maternity assistant planners, your head chief MFMs in the level 4 regional perinatal centers, that level, and ask them to help system change through down the chain. Because once we got the MFMs chief at the regional perinatal centers on board, they took the education then out to the affiliates, the level 3, 2, and 1. So I only met with one person, and they met with their 19 hospitals, and that then enhanced the efforts that we took. Once they did their internal guidelines, which they put inside the guidelines that they use for receiving transfers from their level 1, level 2, level 3s, home birth is right there next to those. It's normal. It becomes normal. Every resident that's in the residency program sees that every single time they're taking a transfer from any of the other hospitals. They see, oh yeah, section G says transfers from home births. So that's normal. That becomes normal, even if they don't themselves take a case right that day or in their practice. So I would really say the system change work can start from the top down, and go for the people who have the power to really help change the system from within.
Does anyone, that's a great summary. Does anyone else have one last parting words? Anything that you would like to include that hasn't been? No, I know that like a lot of the emphasis in the solutions is just improving communication, improving relationships, those communication channels, documentation, and how to share documentation easily for all. Increased education regarding just the different types of providers and the roles of the providers, especially within the transfer. Just different policies and procedures of every establishment. And so basically at this point, I am going to be including a lot of the links in the different places I'll be sharing this. I thank all of you for coming once again and just starting this conversation. And hopefully we'll be able to share this with just a lot of folks out there that, might know it's an issue, might not even know it's an issue, and just kind of starting that conversation on improving this for everyone nationwide, but especially in your community. So thank you, and hopefully everyone can help to share this video. But yeah, that's it. So thank you once again for giving your time.
Thanks for inviting us.
Thank you, Jennifer.
Yeah, and I apologize again. This is not the first time that I've messed up East Coast, West Coast. So sorry about that.
Well,
guys.
yeah, we're glad that you were able to join us.
We're happy for your leadership in the field that you've done for all these 30 years. We're very grateful that you have this voice that we rely on.
Thanks, Kate. Where will this be available?
So I'm going to stop the recording. Once again, thank you but don't go anywhere. Thank you to all that is listening to this.